The first speaker in this session is Dr. Tom Russ. Tom is a consultant old age psychiatrist in Edinburgh, who also has a strong interest in academic aspects of old age psychiatry and has been the director of the Alzheimer's Scotland Dementia Research Centre for the last couple of years as well. He has the task, I'll not say whether it's a good task or a bad task, of following me in my role as the lead for the Neuroprogressive and Dementia Research Network, which he has been running very ably since taking over in April of this year. And he's going to introduce the research strategy of the NDN for the forthcoming years. Okay, Tom?
Thank you very much, Peter. Gosh, I didn't realise how short I am, actually. There we go. That's hopefully better, and hopefully I'm audible, and hopefully audible to the, maybe not hundreds, but hundreds of people who are signed in online. It feels terribly exciting for us to be kind of in the room and not in the room. So I have got the great privilege and joy of launching our strategy, which is launched today. We've been working on it for months and months. It's in the interests of green issues and thinking of COP26 having just been, it's just an electronic publication, but you can get it from the NRS website, and we'll make sure that we send a link to everybody after the conference is over. So I'm going to talk a little bit about the network and what we plan to do in the coming years. And I'll have to remember to do my best Chris Whitty, so if I could have the next slide, please. Perfect. So this rogues gallery is really where the network started. Emma, who you heard from first off, is the stalwart and the last of the leadership team still standing. And Peter and John were the original co-directors of the network, and then latterly Peter was the sole champion of the network. But this is where it all started, back about 12 years ago, as really a huge, exciting development in research in Scotland. And I think very fittingly, last week, I've embarrassed Peter slightly by saying this, both Peter and John were awarded Lifetime Achievement Awards by the Royal College of Psychiatrists and the British Geriatric Society, respectively. And I think that's a very important and great thing that we can mark. So we're very proud of Peter, and John, of course, it was awarded posthumously, but we are similarly proud of him. Many of you know that John died unexpectedly in December 2018, and he continues to be greatly missed. One of my fondest memories of him is in the last couple of years of his life when I attended his New Testament Greek classes. John was a polymath who knew all sorts of things, but one of the things I learned from him was a little bit of Greek. If I could have the next slide, please. Unfortunately, he only ran a beginners and an intermediate class, so my Greek never got to be too good. So I never managed to do the advanced class, but we've all been learning a bit of Greek recently. So if I could have the next slide. I thought, if it's not a little bit too close to the bone, and just to highlight the anxiety that's probably looming in the room, I'm going to base my talk around the variants of concern that the WHO have identified. So if you go to the next slide, please. Alpha, beta, gamma, delta, and Omicron. I couldn't quite work out why they'd skipped so much of the Greek alphabet, but here we are. So I'm going to use this as a chance to take stock about the network, celebrate what the network has been and has done over the number of years, talk about going forward how we really want to bring our partners with us in doing this work, and I'll explain what I mean by that specific word in a moment. Getting everybody involved, I think, is a crucial aspect of the network's work and what we hope to be doing. The core thing that we do is delivering clinical research, and you've already heard a bit about the exciting work of the MND SMART trial, which we're involved in, but that's the core work that we've been doing and will continue to do. And lastly, onwards and upwards to the future. So if I could have the next slide, please. A chance to take stock. And one more slide, please. Those of you who've been around from the beginning will recognize this. Our color does seem to be blue now of the network, but initially everything was yellow. So we started as the Scottish Dementia Clinical Research Network about 12 years ago. And I've got to highlight, I particularly liked our initial logo, which was a saltire flag with a brain superimposed and a big yellow question mark. And I think if that doesn't sum up what we're about, I don't know what could. Of course, things have changed. We are no longer the Scottish Dementia Clinical Research Network with a neuroprogressive and dementia network. We have a much broader remit than we did initially. But thinking about the things that were highlighted for focus back in 2009, 2010, a lot of it still applies. We're interested in including people from all across Scotland, including the rural areas. We're really excited that somebody from an island was recruited to M&D Smart, because we'd love to help people who live in the islands and remote and rural areas participate in research, and we're really exploring what that could be, developing new researchers, reaching new populations, quality and quantity, so doing lots of research but making sure it's really good stuff. Links with the UK and Europe and international bodies as well. And I'll have to crick my neck to look at the right, but we're still doing a lot of that as well. So if we could have the next slide, please. So looking backwards, we are also looking forwards, and this is the very snazzy front cover of our strategy, which, as I say, is available from the NRS network today. I think there are hashtags and all sorts of things that people are doing, and possibly we might break the internet. Who knows? But do have a look at it, because it really summarizes what we've been doing and what we plan to do. And I'm a huge enthusiast and advocate for the network in general, but I'm also very excited about the next few years and where we're hoping to go. So hopefully we can share some of that enthusiasm with you today. And I'm going to share with you some very selected highlights. So one more slide, please. I've been talking in general terms about the network, but the network is, of course, people. And the network includes the participants in all the research that we do, our partners in research, who I'll talk about at the moment, but one of the great joys about actually being together in a room today is the network staff. And this is our last meeting, which was of necessity 2 years ago, just before the pandemic, but also in Glasgow. So it's been great to be able to come together as a team, because we're scattered all across the country, but we are one team, we are one network, and I think there's an enormous value in the staff, the people who we work with. And so, yeah, I wanted to highlight that and celebrate that. But I particularly want to highlight our partners in research. So if we could have one more slide, please. And the partners in research, so we've been very active in PPI as a network for many years, patient and public involvement, so essentially involving normal people. In various different ways. And more recently, that's been developing, and our group named themselves Partners in Research, which I think is a wonderful name, and I think it just sums up exactly what it's about. We've, and I include the network in that, as well as many other people, have been perhaps guilty of doing research to people, but we want to move towards a position where we're doing research with people. And I think our Partners in Research is a way that we can start to do that a bit more. Rosie Ashworth, who sadly can't be here today, is the network member of staff who's leading on the Partners in Research work, and she is an excellent academic in her own right and works some of the time at the University of Stirling and the remainder of her time with the network, but she's leading the Partners in Research stuff, but that's maybe not even the right term, because actually her enthusiasm is co-production of research. So she's perhaps supporting and facilitating this work, but actually it's the group, our partners in research, people with lived experience, people with an interest, who are actually doing this work, and it's all very exciting. We have said in the strategy that we're going to get some external funding, which was maybe not a terribly ambitious commitment, because we already have some by the time it was published. So we're delighted to and very grateful to announce some network research funding from the Royal Society of Edinburgh, which is going to facilitate a project over the next 2 years, developing our partners in research work. Really, the motivation for that is a recognition that there is lots of good work going on across Scotland involving people with lived experience in research. And we want to join with that work, but we don't want to unnecessarily duplicate the excellent work that's going on. We don't want to tread on anybody's toes. So over the next couple of years, we're going to run a series of events, including some online focus groups, and also, hopefully, 4 in-person day-long workshops involving anybody who's interested in co-produced research, involvement of people with lived experience, anything in that area, and all the various different synonyms for that kind of work. But we want to bring everybody together and find out how we can fit in, how we can all coordinate together, and hopefully just do things better than we've been doing them before. And the aim is, and the snazzy logo at the top right, which I've got to confess I came up with, is a clumsy way of trying to demonstrate this, and that we really want to move to a position where our partners in research are put at the center of the network. And we hope that over the course of the next couple of years in this piece of work, that exciting ways that we can work with our partners in research will emerge. We've come up with a few ideas, but actually we're hoping that we'll be surprised by even more exciting ones. And there are things like public engagement and knowledge exchange, but actually we also want to move to a position where our partners in research are having an input in the direction that the network goes in, and the types of research that we're doing, and even if we can work with collaborators and research funders, then our partners in research can be providing feedback on research funding applications to highlight strengths and weaknesses and what could be good and what could be less good. But as I say, we're excited about what might emerge and don't want to be too prescriptive, but I thought I'd share some initial thoughts that we had. Two final points that I think are very important are equitable access. I'll talk a bit more about access to research later, but making sure that actually everybody gets the opportunity of participating if they so wish. We have learned and have a lot to learn from the M&D Smart trial, because that has been fantastic at reaching people and offering people the opportunity of taking part in research. But we need to be doing that across the board, in all conditions, in all regions, in all areas. And there's also a specific piece of work that I think needs to be done around research ethics, because the current research ethics procedures really don't serve people with neuroprogressive conditions and dementia well. They're terribly complex. There's the issue of people who have capacity to consent to take part and the people who don't, being completely separate systems. There's terribly complex and cumbersome applications for social research, which doesn't really fit the type of work that's being done. So I hope that that's an area where some progress can be made, but I think that's certainly an opportunity that we have. Could I have the next slide, please? I've talked about our partners in research, but we have lots of partners of other kinds as well. We're very grateful to and cherish our relationship with Alzheimer's Scotland, who are a fantastic organisation. But we have links with and are developing links with all of these charities and more, hoping to work with them increasingly, not only to link with the partners in research stuff, but also to lobby and to guide the research agenda. And if we could have the next slide, please. And we also have health and academic centres. Of course, as soon as I sent my slides off, I realised everybody had forgot to put on here. So if your organisation or one that you know of is missing, it's solely because I couldn't find the logo on Google. But of course, NHS centres and university centres and the Scottish Dementia Research Consortium, and we could go on. And we mentioned many more of them in the strategy itself. Getting everyone involved, I think, is a crucial point. So if we could have the next slide, please. Really, offering everybody the possibility of taking part in research, I think, is the way, the ideal place that we need to get to. And I think I'll mention hard-to-reach groups later, but if I didn't, I'll mention them now. Because, yes, we need to reach hard-to-reach groups, whether it's people whose first language isn't English, or whether it's people who live in particular areas that make them harder to reach. But the truth is, at the moment, we're not even very good at reaching easy-to-reach groups. So we need to develop more in all of these areas, and really it's a simple message, but I think just offering everybody the possibility of participating in research is where we need to get to. And there are lots of different ways that we can do that. We are enthusiastic supporters of Join Dementia Research, and we're delighted that they've got a banner here, and I think you've got some materials in your packs about them as well. And we use them for almost every dementia trial that we do in the network. It is a fantastic mechanism, and I know Alzheimer's Scotland has got fully behind it as a huge supporter of it in Scotland. We also use Share, and if we could have the next slide, please. But we did also recognise that firstly, that we have a much wider portfolio than just dementia trials. And secondly, that we need to have a GDPR-compliant way of keeping people's details, and importantly, a way that we can allow people to opt in that requires them to do very little, but also which allows us to find out a bit about them which means that we can offer them research opportunities that are tailored to them. Because I think one thing that we do very well as the network is identifying people who might be suitable for a trial before we even invite them along. We do our best to invite people who stand a good chance of being suitable for a particular trial. So we're not just screening anybody and everybody, because it's not fair to raise expectations like that if somebody really is unlikely to fit the criteria. So our permission to contact scheme really fits that bill. It's something that I regularly hand out in the clinic in which I work. It's wonderful. If somebody's not interested, they can very politely say, oh, thank you very much, and use it as a bookmark. But if somebody is interested, they can send it back. It's free post. It takes seconds to complete, but it means that they're consenting that we can keep their details to contact them, but also it asks if we're allowed to look at their medical records, which means we can really do that detailed homework to see if somebody's suitable for a particular trial or not. So this is working really well, and I really want to commend my colleagues in the network who developed this, because I think it's a fantastic mechanism. And it complements JDR and SHARE, because I think we're not at the stage where we're inviting everybody, so I think we do need to be broad and Catholic in our approaches to people. Next slide, please. So delivering clinical research. In a sense, it's a short section, because it's what we do. We've been doing it very well, and I can say that proudly because I've not been responsible for it for the last 12 years. It's Peter and Emma in particular, but we hope to continue doing it really well as well. So next slide, please. But these are the aims, really, as far as I see them. I'll say it again. I think it's maybe the third time I've said it, but it's crucial, I think. We need to offer everybody the chance to take part in research. Many people will say, no, it's maybe not for everybody, but if we don't ask people, then they're not being given the opportunity to take part. We maintain a diverse portfolio of research, and that is deliberate, and I think that's something to be celebrated. That includes diverse in terms of who's running the research. So we do a lot of commercial research, but we also do a lot of academic research from academic centres, and I think it's important to have that combination. But also diverse in terms of the conditions covered, the neuroprogressive conditions and dementias. It's important for us to have the balance between those. And MND SMART is such an impressive trial. It's been really great to hear more about that today. And we've learned an awful lot from being involved in that trial. But we also have a lot of expertise in dementia studies. So I think making sure that we keep that broad expertise and that diversity of research is really important. One of the studies that we've been involved with from the start is the Scottish Dementia Brain Tissue Bank, which is run in collaboration with the Alzheimer's Scotland Dementia Research Centre, where by anybody with a diagnosis of dementia in Scotland can sign up to donate their brain tissue after they die, if they so wish. This is a fantastic resource that we are improving and developing all the time. We've just had ethical approval to change the system slightly, in that we can recontact people every year to retest their cognition, to see how things are developing over time. And we're beginning to explore possibilities of approaching specific groups of people who have additional information that it would be helpful to combine with their brain tissue eventually, because it's the clinical data associated with the pathological samples that really makes this such a fantastic research resource. And it's already great, but there's possibilities of making it even better, and we look forward to developing that in the coming years. And lastly, I know we're hearing more about Enrich later in the day, but it's worth saying that we're very, very proud to have our links with Enrich Scotland. The pandemic has highlighted for us, if nothing else, that people in care homes are often neglected and not thought about as much as they are. Enrich stands for Enabling Research in Care Homes. And I won't say much more about it because we're hearing from Susie Schenkin about that later today, but it's a really exciting and I think really important endeavour. Can we have another slide, please? And so onwards and upwards. And one more. So really, this is my summary slide as well. This is where we need to go. We need to carry on onwards, doing what we've been doing, but also upwards, seeking ways to do it ever better. So possibly for the fourth time, we need to offer everybody the possibility of taking part in research. And this is where I talk about hard-to-reach groups. We need to identify and reach out to hard-to-reach groups, but whilst still continuing to reach out to the easy-to-reach groups that we're not actually finding that easy to reach. We are going to continue our activities, but expand them and improve them, focusing on quality and quantity, as the initial yellow slide highlighted. I've mentioned our developments in the Brain Tissue Bank, and I'm really excited about the Partners in Research work, and particularly what may emerge from the Royal Society of Edinburgh grant. I honestly don't know what's going to come of these meetings and this work, but I can guarantee it's going to be exciting. And so my final thought is that really the purpose and hope of the network is to bring the best research and best research opportunities to Scotland, to not solely for the point of doing academic research, to really make a difference to the lives of people who are affected by neuroprogressive conditions and dementia, because that's what it's all about. That's why we're doing research, because we want to make a difference. So thank you very much.
Thanks very much, Tom, for condensing what's really a very extensive topic into such a brief presentation and very clearly presented. Any queries from the floor to begin with? They're all very quiet today. You know, normally you go to Scotland and something, you know, everyone wants to ask you something. Yes. Right, Agnes first then.
But it's great, so thank you very much. I was asked to thank you by people living with dementia, and I was asked by people living with dementia to be here today. So thank you.
Yes, and of course you're most welcome, Agnes, as you know. Susie?
Thanks very much, Tom. It was terrific. I'm Susan Shankman. I'm a geriatrician in Edinburgh, and I co-chair in Rich Scotland. You'll hear from me later. But just, I suppose, a question to the audience and all the people listening. How many of you are registered for SHARE and or doing dementia research? I'll just leave that there. You don't need to share if you want to, but you know, in the next, between now and lunchtime, you can all sign up if you want to.
Not to forget the permission to contact either. Yes. Okay, well, thanks very much, Tom, and I'll move on to the next talk, which is going to be online, I believe. So the next talk is a joint presentation between Catherine Walesby and Graziella Manus-Terrera. And Catherine is also a geriatrician who has moved to Edinburgh to work. Graziella is really a senior lecturer in biostatistics and epidemiology, working at the Centre for Dementia Prevention in Edinburgh. And these our two speakers had an involvement in EPAD, which was probably the most extensive project to try and acquire data in people who were cognitively normal, who might progress on to develop dementia. Unfortunately, the second phase of that, which would have involved the type of trial that Savanker so eloquently described, being done, an adaptive multi-arm design, but unfortunately that didn't go ahead, and we still await alternatives from other potential sources. So Catherine and Graziella are going to talk about rural and urban differences in dementia, and I will hand over to them.
Thank you very much. I'm going to talk first, and then Graziella is going to follow, developing some more discussion points, and hopefully we'll have lots of questions from you as well. Can everyone hear me okay? hopefully no answer is good. I'm going to try and share my slides now. I'll just check. Can everyone see those slides okay?
Yes, we can.
Thank you. So my name is Catherine Walesby. I'm a clinical research fellow in geriatric medicine and a specialist registrar, and I'm at Alzheimer's Scotland Dementia Research Centre. I'm undertaking my PhD on geographical variation of dementia, and that's involved looking at this within big data sets in both Scotland and New Zealand, and another large chunk of it is a systematic review looking at rural and urban dementia differences and the variation. So that's the part that we're going to focus on today, and I'm going to give some preliminary findings from the systematic review, and Graciela is going to follow with having some discussion around why there may be differences between rural and urban dementia rates. So the background, as you all know, worldwide dementia prevalence is expected to rise to around 78 million in 2030. The greatest increase is expected in developing countries, and there's been a lot of work previously highlighting that there could be geographical variation of dementia. In particular, I'm showing Tom Russ's work from before, looking at a Scottish cohort, and as you can see in the maps, the odds ratio is higher in the north than the south of the country in terms of dementia, and this has been shown also in other countries, including in Sweden in the Swedish twin study. Another important factor in all of this is obviously the recent Lancet report 2020 that added 3 more risk factors for dementia, one of them being air pollution. And obviously that's important in terms of environmental risk factors that might influence differences depending on where you live. Some of the work that I've published, and there's a poster up today on that, is looking at the differences in New Zealand in the geographical variation of dementia. I'm going to briefly show you this in the slide and focus the rest of the presentation on the systematic review, but if you're interested, the QR code there should work for the full paper published. We used big data and ascertained who had dementia and where they lived, and we showed that there was higher dementia rates in the north and the south of the island over a series of 4-year period. So the results were interesting as they were slightly lower than national current estimates, which are not based on New Zealand's data and are extrapolated from other countries. As I've demonstrated, it was higher in the north than the south, and we'll discuss some of the differences in general about geographical variation of dementia, and particularly rural versus urban. And they were different in different ethnicities as well. So the focus of this presentation is the systematic review, which you can find registered via Prospero here. So a previous systematic review done in 2010 highlighted increased dementia in rural areas. Now, this was very interesting. It also highlighted that there was a lot of heterogeneity in the methodology, so it was hard to conclusively tease out the true differences, but that the odds ratios were higher in rural area than urban. Since then, there's been an explosion of papers investigating geographical variation of dementia, and that's partly because there's also a growing interest in health-related outcomes related to the environment in general. So you'll be aware there's many other chronic conditions where people are interested in where you live and your risk factor for developing them. So when we repeated this systematic review, we found that there was such an explosion of papers that rather than doing a whole geographical variation of dementia, including country-to-country comparisons and different levels of geographical comparison, we had to focus it down to rural versus urban dementia just due to the sheer volume of studies. So I think that kind of represents it's an interesting area that's expanding. So these are preliminary results. We hope to submit in the coming weeks, months, so I would be grateful if you don't tweet these preliminary results. We started our systematic review doing a large database search, and as you can see, there was a a large number of records identified, new records since 2010 of over 20,000 studies. We managed to deduplicate them and screen them down slightly to around over 13,000 that we had to screen the titles and abstracts. And after excluding a few more, we managed to get it down to 530 full text to review. This was still quite a substantial systematic review. When we excluded reports at that level, there was a number of reasons, as you can see on the right-hand side, including that they weren't looking at the patient population we were looking for, or that they weren't comparing two geographical areas, or there was no spatial variable as well. This left us in the included studies at the bottom with actually on the left you can see 154 studies included, which is why we had to narrow down to actually look at rural versus urban. So we had 38 in the final analysis looking at rural versus urban, and 27 of them in the meta-analysis, which was actually more than we had anticipated for the meta-analysis. So this, as you'll be aware, is a forest plot of our results and the studies that were included in the meta-analysis. They're listed in terms of alphabetical order of the studies, and the years you can see, and the countries in terms of, there were a few countries that had produced several studies looking at geographical variation, China being one of them, USA being another one, but we did have a spread across countries that were both considered resource-rich countries and resource-poor countries. The size in the next column you can see varies substantially, and there were some very, very large studies, and those studies were done undertaken using electronic health data, so big data, and were all done in resource-rich countries. Moving to the next column, you can see the rural on the left of the midline and urban on the right. And what this means is that the studies that were moving to the left in the rural area showed that there were higher odds ratio of rural risk of dementia. And the studies on the right of the midline showed that the odds ratio for dementia were higher in the urban areas. Now, many of the studies had very wide confidence intervals, and overall, there wasn't really any conclusive result that we could take from this. Most of them, as you can see, are centred around the midline. Nextly, we obviously did a risk of bias, and most of you will be familiar with this within a systematic review. We scored the studies based on whether there was any bias in who they selected as participants, the confounding variables that might affect the outcome results, the measurement of exposure, and for us that was geographical variation, so rural versus urban, and how they defined their geographical area and how they defined rural versus urban. And then also we looked at risk of bias in terms of the incomplete data, what they did with missing data, and how they selective outcome reporting as well. I think the key finding from this is that the measurement of exposure, which is obviously really the key thing we're looking at in terms of rural versus urban, had over 50% in the high risk of bias, and a lot further in the some concerns or unclear. And what this means is that we weren't convinced that there wasn't risk of bias in how they defined rural and urban, and that was apparent because a lot of the methodologies didn't actually describe how they defined rural and urban. Some did, and this varied between different countries, and we'll chat a bit more about this in the discussion, but it is quite important to kind of consider that aspect of risk of bias in our results. So we did some other sensitivity analysis by removing the high risk of bias studies, particularly the ones for the measurement of exposure that didn't really describe rural and urban areas and how they defined it clearly, and that didn't actually make any difference in the overall forest plot when we plotted it again, or the overall odds. And we also removed resource rich and separated resource rich countries to see if there was any difference there, and we separated the countries and studies that used electronic health data, so those massive population samples, just to see that we weren't seeing any bias when we were doing our meta-analysis. And changing all those factors didn't actually alter the overall results from that forest plot that I showed you earlier. So I think the key findings from the systematic review are that obviously geographical location is important. We're having growing interest in where you live and your risk of health and where you might access services or not be able to access services. But when we're looking at it in a systematic review, what do we really mean by this? Because there are rural and urban differences in different countries, and trying to combine them when there's different variation in the methodology, and in particularly how they may or may not define rural and urban, is quite important to consider when we're analysing what we might be thinking as, oh, this area may have a higher risk of dementia versus another area. The ascertainment of dementia was varied, and there was different methodologies across all the papers. Obviously, the cohorts that used electronic health data and big data used ICD-10 codes, and we don't know what went into the defining that person getting the ICD code. So what methods were used to ascertain dementia, and what cognitive tests were used for them to then have an ICD-10 codes. And that's the limitation with all big data. And then the more traditional epidemiological studies, face-to-face, they had smaller sample sizes. They often used several phases of assessment, a screening survey followed by a battery of cognitive tests, and some of them also imaging as well to define dementia. There were predominantly larger studies from resource-rich countries, although we removed the electronic health data ones, which were massive, large studies, and it didn't alter the results. But it is something to consider moving forwards when you're looking at geographical variation at an international level, and the explosion in interest in big data that is largely in resource-rich countries. Lastly, the two last points are very closely linked, but there is a life course approach, obviously, to your risk of dementia, age being the biggest risk for dementia, and this increasing significantly from when you're 40, 50, to 60 to 80. But across the whole life course, there are critical periods, as we say in epidemiology, that may or may not produce risk factors for dementia, or indeed you may have a protective factor for dementia. And what we know is, looking at geographical variation of dementia, and particularly rural versus urban, late in life is not always very effective, particularly if you look at mortality data. So where you die is not necessarily going to be meaningful, because that might actually just report where someone is in terms of a care home, rather than their actual risk of living in a rural or urban environment. And so trying to establish actually what is the true risk of living in a rural and urban area needs to factor in that life course approach, but many of the studies obviously don't, because of the nature of dementia being something that you get later in life. There were only a few studies that looked at dementia at different points in time, and only one that actually looked at childhood versus adulthood residents in terms of your rural and urban risk, and compared this with your risk of dementia. And that's probably something that going forwards, more studies need to look at different points in time to actually get a meaningful conclusion of rural, the risks of rural versus urban living and dementia. So before I hand over on to Graciela, who's going to talk a bit more about why could there be differences between rural and urban dementia rates, just like to thank obviously the funding bodies, my supervisors, co-authors, and the team in New Zealand that I worked with. Thank you very much.
So thanks, Catherine, and thanks, Tom, for the invitation to present. It's fantastic to be here today. And I wish I could be there in person, but I'm self-isolating because I just came back from the US, so I'm waiting for my COVID test results. So that's the reason why I'm not there in person. So Catherine presented the results of this systematic review, which she has been working on, and I think that the results are very informative, and particularly my reading of the findings is that there's a lot to be done, that needs to be done to really understand the differences in rural and urban aging populations, and particularly in relation to dementia. And one of the aspects that was really striking is how heterogeneous the definition of a rural environment, a rural setting is across countries and within countries. So that is a serious limitation. Well, I'm not sure. I used to say limitation, but perhaps it's not a limitation. But that is a factor that is potentially undermining the strength of the conclusions that we could come up with. Another aspect that the systematic review highlighted, and Catherine's presentation also was very clear about that, is that we don't really know about the prevalence of risk factors across in rural areas. And particularly if we start thinking of the life course, that is a key issue. So if we think of the, say, Lancet Commission report and the risk factors highlighted in the Lancet Commission report, it would be really interesting to try to see the differences in prevalence of these risk factors, again, within and across rural and urban settings, with some sort of definition of rural and urban setting that within the studies we could look into. And particularly, this is really important to look at population representative studies, because some of the studies are not really population representative. So that would be another factor that needs to be taken into account. Another aspect that I thought that was really interesting is that when we think of the rural and urban settings and the wider health disparities are seriously confounded. I'm just bringing up an example of a study I am working, a data set I am affiliated to is a study of in Bangalore in India, and it's a rural study. And if we think, well, it's true, it is rural, but the population involved in that study is over 90% is illiterate, and there's for example, men are slightly more educated than women. So is it the rural, or is it the general socio-demographic setting of these populations that are driving the factors that we are seeing in terms of aging and dementia in these groups? So those are aspects that I think that really need to be addressed and fully understood a bit more, or understood a bit more. And another aspect that Catherine was highlighting is the differences in access to resources and to healthcare and diagnosis. So, as I just mentioned, I was in the US until 2 days ago. And it was really interesting because I was working in well, in a rural study in Ohio, Kentucky, and Tennessee, and Arkansas. And what we were discussing with the local investigators was the lack of opportunities that the individuals living in rural areas in these states have in terms of, socializing, engaging in cognitively engaging activities and things like that. So of a healthier lifestyle is harder for populations in those settings. So it's the access to these resources, to opportunities in rural settings is more limited to the access of this opportunity and healthier lifestyles that urban populations may have. So that's another factor that needs to be considered. And of course, healthcare and diagnosis is another aspect that I think that somehow we are fortunate in the UK to have, access to healthcare and diagnosis. But still, I think we could work a bit more in that regard in terms of understanding the impact of being in a rural setting. Catherine also mentioned that most of the work, most of the evidence that we have comes from rich contexts, rich countries. And I think that is absolutely true, and it's coming out in her review. But also, currently, there's if you want, there's a push, or there's a sort of energy in the system, in the research system, in terms of research in dementia in low and middle income countries. And even though in the context of low and middle income countries, we use that term as a big umbrella, the differences in rural and urban populations in those countries is also really shocking. And for example, in America, there's the issue of depopulation. Right? So all these rural settings, rural areas are becoming depopulated. Right? But also there are geographical variations. For instance, in the southern part of the US, that's one of the bigger sources of information about this topic. In the southern part of the US, you have a lot of migrant population, so Latino, farmer, workers working in farms, for instance. Whereas in the middle part of the country, we don't see this ethnic variation, but so we have a predominantly white population, but it's also, the younger generations are leaving the place. So those are aspects that may be happening more in some countries than in others. So again, even though we are trying to get more information, the variety, the variations in the studies, in the populations and the context is really quite important here. Definitely, I am 100% certain that we need more research with this focus and on rural and urban differences. But there's another aspect that is that has been discussed quite a bit in the literature in this area, is that it would not be adequate to talk about a unique rural aging profile, if you want. That there are too many differences and too many factors that affect this idea of rural aging, and therefore, like, putting all these factors and trying to figure it out as a unique single process might not be the best way forward. So there's some research coming out of, again, from the US, looking at the southern part of the country and the northern part of the country, and saying, well, fine, these are both rural settings, but need to understand because the factors there are different. So I think that particularly if we bring it back to the UK, I think we have fantastic opportunities. And say in Scotland, it's a country geographically relatively easier to understand, and with opportunities such as Generation Scotland and others, I think there's great opportunities to do research on rural aging in Scotland. So with that, I'd like to finish and happy to answer any questions. Thank you.
Okay, so thanks again to both of you for a very comprehensive presentation on a most interesting topic about where factors perhaps unthought of in the past might influence how dementia is developing in an ever-increasing population that we have.
We are not having any questions, or
well, I'm just maybe. But anyone from the floor with any questions? Oh, there is one on the chat that I see, which is about, and this is probably for Catherine, how about looking at data where the patient was living at the point of dementia diagnosis? Would this influence the outcome of the review?
Yeah, no, I think this is really important, and obviously the ideal study would be to do that. From some of the studies where they've gone, the face-to-face to ascertain who's got dementia, done a screening assessment, and then focused on the ones that didn't already have dementia diagnosed. I suppose there's difficulties in knowing when they really got dementia. You're giving a diagnosis based on a study that you're going there to recruit and find people, but actually that doesn't necessarily mean they haven't had dementia for a while, they've just not had it diagnosed. So I think definitely your ideal study would be to have a life course approach, know exactly when they get diagnosed with dementia, have several points in time where you can factor in where they were at points in their life geographically, and then factor that all into your analysis. Unfortunately, those perfect studies don't really exist. So yeah, I mean, it would be great to have a lot of studies that knew that actually that was the point in time dementia was diagnosed, but that can be hard to actually capture in real time.
Okay, thanks. And a second question is about sort of subgrouping the results. So if you were to group all the studies where rural was greater than urban, and group those where urban was greater than rural, would there be systematic factors or patterns that could explain the observed heterogeneity?
That's a very good question, and one we probably need to look a little bit more into for the final results that we're going to put into to be published. But there is still a lot of variation in terms of some of them would capture cardiovascular risk factors and some of them wouldn't. The very interesting study that's done in America, the Indianapolis group, looking at African Americans, and that was the one that looked at childhood residents and adulthood residents, and they found that years of education played a factor in decreased risk of dementia for those that were living in a rural environment in childhood, but didn't have the same impact if you were living in an urban environment in childhood. So I think definitely looking at the factors, the variables that influence the differences are important, but there's also that life course effect that is actually really, really important to try and capture, and a lot of the studies don't look at that. I mean, that has many variables there that can perhaps be influencing it, not just education, but obviously ethnicity, and also that cohort had a big movement from south of America up to the north during their lifetime. So yeah, there's much more to be done in terms of trying to understand more of the variables involved, as Graciela said, in terms of the variation between rural and urban studies. Unfortunately, some of the studies are so heterogeneous in what they collect and their methodology that it's hard to kind of clearly differentiate that in the meta-analysis.
adding to that, I see that this question comes also from Mario, who is very familiar with the low and middle income countries context. And you know how hard it is. So if it is hard to do research in rural settings, in high income contexts, I'm pretty sure that it can be appreciated how difficult it is to do
absolutely
research in low and middle income countries. So again, I think it is in terms of opportunities rather than limitations.
Okay, and the final question before lunch is, what about rural versus urban differences in different types of dementia? Arguing perhaps vascular dementia might be more prevalent in urban settings.
Yeah, definitely. This is a really important question. And one you'd think it would be higher in urban settings. Unfortunately, only a few of the studies actually differentiated, also capturing that those results for rural and urban to create odds ratios for the different subsets of dementia. And I think there's a long way to go with that, because even in the big data that I analysed in New Zealand, and that's electronically captured health data, the different subtypes is even less well recorded than overall dementia. And so a lot of the studies that you find in the systematic review are just talking about dementia in a broad umbrella term. Some of them do specify specifically Alzheimer's dementia, particularly when it's in the electronic health records and it's easier to extract those ICD-10 codes. And a lot of them, there was only a couple that actually did vascular dementia, and nothing really that meaningful that we could actually do any meta-analysis on, unfortunately. Yeah, it would be really important to try and understand that more. But to get to that stage, we have to go back to having better coding, having the right diagnosis put in to electronic health data for those studies, as well as having face-to-face epidemiological studies that are able to kind of work out whether it's vascular versus Alzheimer's, and a lot of them are looking at it in a broad term. But I think that is really important in moving forwards.
Okay, so thanks very much, Catherine. So we can bring the morning session to a close now, and it's lunchtime. So I've asked you to just do the same as the coffee and pick up your lunch, and then come in and feel free to circulate around in the larger room here. But try not all congregate in the small area where lunch is being served. Is that right, Emma? It's just, yeah. Okay, and then we should see you back at 1 o'clock, and we'll start the afternoon session then.